Thank you very much. Good morning, good afternoon. I'm glad to be the moderator of this webinar, co-organized with colleagues from WHO headquarters, the Swiss Tropical and Public Health Institute, the UNEP and the Minamata Convention Secretariat, in this scenario of multi-stakeholder efforts across global, regional, and national and local levels, which are key to the identification of environmental public health concerns among artisanal and small-scale gold mining communities. We recognize the social and economic relevance of the ASGM sector in the region and the challenges of the health sector to address the broad range of ASGM-related health hazards. The objective of this webinar is to raise awareness and to facilitate actions to be taken by the health sector to develop the national public health strategy. For that purpose, our agenda that I think will be shared in a moment. Today, we will share knowledge regarding the development of WHO guidance documents to draft the national public health strategy and the related experiences acquired in piloting countries, which were Mozambique, Ghana, and Nigeria, by the Swiss Tropical and Public Health Institute, working with WHO. We have also a regional panel that will share country experiences on health and mercury exposures in ASGM-related communities from Brazil, Honduras, Peru, and Suriname. To recall, I will be looking at the Q&A icon to facilitate responses from speakers. And to continue, I would like to invite Marcelo Cork, Unit Chief of Climate Change and the Environmental Determinants of Health, to share some additional comments. Thanks for your attention. Marcelo, the floor is yours.
Muchas gracias, Ana. Muchas gracias por las palabras y
Thank
por
you
la
very much, Anna,
bienvenida.
and for those words of
Bienvenidos
welcome,
a todos.
and welcome to
Buenos
everyone.
días,
Good
buenas
morning, good
tardes, donde
afternoon,
estén.
depending
Muchas
on where you
gracias a
find
nuestra
yourselves located,
organización
and
hermana, la
many
Organización
thanks to
Mundial de la
our
Salud, a
partners at
Caroline
the World
Bakers en
Health
particular como
Organization,
jefa del
and
programa de
particularly
seguridad
to
química. Por
the
supuesto que
head
a ti, Ana, por
of the
responsable de todo el tema
Health
de
Hazards
seguridad
Program and
química y
everything
más que
having to do with
nada al
chemical
Instituto
safety, and
Suizo de
above
Salud
all
Pública y
the
Tropical por
Swiss
apoyarnos en este
Tropical and Public
proceso de
Health
exponer
Institute for
este
help us
webinar
in
el
the
día de hoy.
process of putting on this webinar
La
today.
importancia del
The
documento de
importance
orientación que
of
vamos a ver
the
esta mañana
guidance
sobre el
document that
desarrollo
we're
de
going
las
to look at today
estrategias de
on the
salud
development of
pública
public
en el
health
contexto del
strategies
convenio de
in the
Minamata
context of the
es
Minamata
crucial para la
Convention
Organización Panamericana de la Salud
is
y para nuestra
very important
agenda
to the Pan
para las
American Health
Américas en
Organization and
salud,
for
ambiente
our
y cambio
Health,
climático
Environment, and Climate
2021-2030.
Change
Es crucial porque es uno de
2020-2021
los
agenda. It's
componentes
crucial because it is one
centrales
of the
dentro de
central
las líneas
components
estratégicas
within
que
the
nos hemos
strategic
marcado
lines
para los
that we have
próximos
laid out
9 a
for
10
the next
años
9 to
en el
10
marco de la
years
Agenda
within the
2030.
framework of the
Primero, en nuestra
2030
agenda
Sustainable
tenemos
Development
tres líneas
Agenda. We have three
estratégicas.
strategic
Una
lines.
es cómo
The
mejorar el
first is
desempeño
how
de
to
los
improve
programas e
the
instituciones
performance
de
of
salud pública
public
ambiental en los países.
environmental health
Dos,
programs
cómo
in the
podemos
countries, and
fomentar
how
que
we
tengamos un
can
sector salud que sea
foster
más
a health
resiliente
sector
y
that is more
ambientalmente
resilient and
sostenible. Y
environmentally
tres,
sustainable.
cómo
And
podemos
three,
promover
how we
comunidades
can
y
promote
ciudades para que sean
communities and
ambientalmente
cities
más
that
saludables
are
y
more
resilientes.
environmentally
Como pueden
healthy
ver,
and
estas líneas
resilient. As you can see,
estratégicas
these
van de
strategic
la
lines
mano
go
con
hand
lo que
in
vamos a
hand
ver el
with
día
what
de
we
hoy.
are going to see
Las
today.
comunidades que son
Communities,
comunidades mineras,
mining,
artesanales, de la minería del oro,
and
que son de poca
artisanal,
escala,
small
de pequeña
scale
escala,
gold
es un
mining
componente
communities. This is a
crucial
crucial
para poder llegar
component
y decir
for
realmente
being able
llegamos a
to
toda la
say that we have
población.
truly
Es
reached the
sumamente
entire
importante que
population. It is
trabajemos no
extremely
solamente
important for us to
desde
not
el programa de
only
salud
work
pública
in terms
ambiental,
of the
sino que
environmental public
trabajemos
health
también
program,
con
but
colegas
to
de otros
also
sectores
work
de la
with
salud,
colleagues in
como
other
por ejemplo
sectors
el
of health,
programa de
such as
malaria,
the
ya
malaria
que el programa de
program,
malaria,
since the
junto con
malaria
el programa de
program,
salud
together with the
ambiental,
environmental health
necesitan poner
program,
en el centro a
need
este
to
tipo de
be placed at
comunidades.
the
Si
center of these
ponemos a las
kinds of
personas en el
communities.
centro, las
If we have
comunidades más
people and
necesitadas, como estas
focused
comunidades,
approaches,
comunidades
the
que son
media's people in
vulnerables,
these
de
vulnerable
pobreza, que tienen de
communities
por sí una
affected by
situación
poverty
económica
and
precaria, de
have
vivienda precaria, en
precarious
ecosistemas
housing
precarios,
economies
indican que no
and
solamente
ecosystems.
deberíamos
This
verlo
means that
desde
we
un
not
punto de
only have to
vista,
look at
no
them
verlo solamente
from,
desde una
we have to look
enfermedad,
at them
sino de
not
una
just
forma
from
integral.
one
Y es
advantage point
así
in
que
terms of
bajo el
one
desarrollo de
disease,
las
but we have to
estrategias
look
de
at the
salud
development of
pública en el
public health
contexto del convenio de
strategies
Minamata,
within the
donde
context
podamos
of the Minamata
incluir
Convention.
las medidas de
We
salud
can
pública
implement
dentro de los
public
planes
health
de acción nacional
strategies within the national
del
development
convenio
plans
y así
and
también
national
trabajar de
plans
una
for
forma
implementation of
integral,
the convention, and
tanto
then work
dentro como
together
fuera del sector
and
salud,
comprehensively
nos
within and outside
permitirá
the health
decir
sector,
que
in
al
order to be able to
2030
say that by
hemos logrado
2030 we
y que
will have achieved this and no one will be left behind. With this, many thanks. I wish to particularly thank the Eisaku Toda from the Secretariat of the Minamata Convention, and also Carolyn of WHO, because we always work hand in hand with you on these programs. Thank you very much, and we hope that this session will be a success. Thank you, Anna. Thank you, Anna.
I would like to continue with the opening remarks with Eisaku Toda, who is the Senior Program Officer of the Secretariat of the Minamata Convention, to share some highlights of the convention and the status of key documents and obligations on the ASGM. Eisaku, the floor is yours.
Thank you, Anna, and a very warm welcome to our colleagues in the Americas. Thank you, WHO PAHO and the Swiss TPH for the leadership in organizing this event. And also congratulations to the WHO guidance document on the development of public health strategies in the context of Minamata Convention. The objective of the Minamata Convention is to protect the human health and the environment from mercury. Article 16 on health aspects is a key provision of the convention, especially on artisanal and small-scale gold mining, ASGM. Parties with ASGM in the territory has an obligation to develop, implement, and review a national action plan that includes a public health strategy and strategies to prevent the exposure of vulnerable populations to mercury. Guidance document for the development of National Action Plan, NAP, was adopted at the first meeting of the Conference of the Parties, COP, in 2017. A document that proposes amendments to this guidance is tabled for COP4, which includes guidance on health aspects and refer to the WHO guidance document. COP4 will start in an online format on the 1st of November and will adjourn on the 5th of November, and then will resume in an in-person format in Bali, Indonesia, hopefully in late March. The proposed amendment to the guidance will be considered at that resumed meeting. I believe that parties will enthusiastically welcome the new WHO guidance at COP4, and they will already use this guidance to protect the human health in ASGM communities. I look forward to a fruitful information exchange at this webinar. Thank you very much.
Thank you, Isaldo. And now I would like to share that I was asked to share some apologies from Jorge Pon, Regional Coordinator for Chemicals, Waste and Air Quality in Latin America and the Caribbean, United Nations Environmental Program. Jorge is unable to join us here as he is moderating another meeting at the same time, but he did send me some nice words that I'm glad to share. Here they are. On behalf of UNEP, Latin America and the Caribbean Office, we would like to express our appreciation to PAHO for the invitation and organization of this important event. In Latin America and the Caribbean, according to the estimates of the Global Mercury Partnership, ASGM is the main activity driving the demand, use, and emissions and releases of mercury. This activity takes place in more than 12 countries of the region, involving more than 500,000 miners. It also accounts for about 8% of atmospheric emissions and releases in the region. Accordingly, this represents a major source of exposure to affected communities and the environment. In this sense, the WHO guidance document on the development of public health strategies in the context of the Minamata Convention and its use for the development of ASGM National Action Plan is of crucial importance to properly address this issue. The integrated approach of the health and environmental dimension is a key element and distinction of the Minamata Convention, and we'll be pleased to continue working together with WHO and PAHO and global and regional level partners to support the effective implementation of this approach. Jordi wishes us a fruitful session and exchange of experiences today. With that, I think I am closing this opening section, and I would like to invite participants to share some thoughts that we have organized in a poll format. That is how we meet nowadays in this virtual divide. So the first question that we would like to share with you is the public health in the ASGM context. If you consider that public health is an important issue in the ASGM context, there is only one choice for you to choose. You are most welcome to put your responses while we pause for half a minute to see what is your consideration about this question. That's the first question. I'll put another one very soon. And I think colleagues from Swiss Institute will be dealing with the responses to be shared. So here we have lots of people responding.
And Anna, what you can see now is already the outcome of this first poll.
Okay, so there is a strongly agree dominance on that. I'm glad we are under agreement for the first question. We can go now for the second question, which is how significant is the ASGM sector in your country considering economic terms? And here are the options that you can choose. And we'll be sharing the results at the same time. Here are the results. Some people say it's extremely significant, others it's very significant, and only few people would agree that it's not significant at all. And I think this is closely related to the country you are coming from. because it varies a lot as we understand. Thank you very much for your participation. It's good to warm up before we start the next section, which is the National Action Plan guidance that will be presented by Susan Kim, who is a senior director at Natural Resources Defense Council and the co-lead of the ASGM area of the Global Mercury Partnership. She'll talk about the National Action Plan as addressed in the Article 7, Annex C of the Convention. Susan, the floor is yours.
Great. Thank you very much, Anna, and hello to everyone. I appreciate your participation in this important event. If you could display the presentation now. So I'm going to be focusing on just giving an overview of national action plans that are required under the Minamata Convention for reducing and, where feasible, eliminating the use of mercury in ASGM, in artisanal and small-scale gold mining. Next slide, please. So before I start with that, though, I wanted to just give a quick overview of the global ASGM sector for those who may not be as familiar with it. ASGM collectively produces about 20% of the world's gold. It employs somewhere around 15 million people. That number is quite uncertain, but that's a median estimate. Typically in remote rural areas. This includes 4 to 5 million women and children who participate in various capacities in the sector. ASGM takes place in at least 70 countries. We think there's probably a lot more than that, but at least 70 countries, and often in areas where there is limited economic opportunity. So there really aren't alternative livelihoods available in many of these areas. Collectively, the sector releases about 35% of all mercury air pollution to the environment. And that doesn't include, that figure doesn't include the releases to land and water because those, the amounts are not as well quantified as the releases to air, but they are quite significant. And finally, the sector in most countries is considered informal. Next slide, please. So you might ask, for such a toxic chemical, why is mercury used in small-scale gold mining? The most important reason is that the process in which it is used, amalgamation, is very cheap and fast and easy to use. It doesn't require a lot of training to use this technique. Mercury is still widely available, even now with the Minamata Convention, with controls on trade, it nonetheless is still relatively widely available. There's a little to no information on the risks for the miners. The miners don't really understand the health risks associated with mercury, or if they do understand them, they might deprioritize them. They're not as important as other risks and issues that they face in their lives. The miners often have no formal training around alternative technologies. The use of mercury is the only way they know how to extract gold. And finally, there are often business reasons why mercury is used. Gold traders often are the suppliers of mercury to the miners. And the deal is that the miners then sell the gold back to those traders at a discounted price. So there's a very entrenched business relationship that perpetuates the continued use of mercury in many places. Next slide, please. So of course, there are significant impacts, environmental and health impacts of the use of mercury in ASGM. Mercury emissions to the atmosphere occur when the amalgam is burned in order to recover the gold. And that of course has really dramatic occupational health consequences for the miners themselves, for their communities, and frankly, for the global environment as mercury is released into the global atmosphere. Mercury is also released to soil and groundwater during its use and can also be released directly to surface waters in uncontrolled uses and situations. And that results in the contamination of soil, water, and the food chain, especially fish, with mercury. Next slide, please. So recognizing the importance of this sector and its significance to global mercury pollution, under Article 7 of the Minamata Convention, ASGM countries are required to take steps to reduce and, where feasible, eliminate mercury in small-scale gold mining. I want to clarify, Isako mentioned Article 16, which is the provision of the Minamata Convention that covers general health aspects. But in addition, Article 7 specifically focuses on ASGM. Next slide, please. Within Article 7, countries that have more than insignificant ASGM in their territory are required to develop a national action plan that includes strategies to reduce and, where feasible, eliminate mercury in the sector. I know more than insignificant sounds like a very legal term, which it is. What it really just means is that if the country itself feels like it has a serious problem with ASGM, it declares that so to the Secretariat, and then it has to create a national action plan. As Isako mentioned, there is a guidance document that was approved by the COP at COP1 that describes how to develop a national action plan. And at COP4, there will be further amendments considered to this guidance document, including the incorporation of the WHO documents that we'll hear more about today. Next slide, please. The contents of the National Action Plan are defined specifically according to Annex C of the convention. So that is, countries aren't at liberty to just include whatever they wish in the action plans. There's a very proscribed list of types of strategies that they need to include, which you can see in this diagram here. So relevant to this audience, the strategies must, very importantly, include a public health strategy on the exposure of miners and their communities to mercury. And a related provision are strategies to prevent the exposure of vulnerable populations. Next slide, please. So Annex C goes on to specify that the public health strategy needs to include provisions for gathering of health data, the training of healthcare providers, awareness raising through health facilities, and other provisions. The related requirement on the prevention of exposures to vulnerable populations focuses on women of childbearing age, especially pregnant women, and of course, children. I want to note that measures to prevent exposures to children can be included as part of the public health strategy, and or there can be other policy tools used. For example, the more rigorous enforcement of child labor laws can be used so that the children are not present on the mining sites to begin with. Next slide, please. To date, 41 countries have started the development of their national action plans for ASGM. Most of those countries are in Africa, as you can see from this map. But there are several in the Latin America region which have already commenced this process. Next slide, please. To date, though, only 16 of those countries have actually completed the process and submitted their national action plans to the Secretariat of the Minamata Convention as required by Article 7. So congratulations to Ecuador, if there's anyone on the phone, the first in the Latin America region to have submitted their NAP. But we hope that others are, they're in their process of finalizing these plans and will be submitting them soon. Next slide, please. I want to mention that there are a number of available resources for the development of NAPs. There's a dedicated site for various types of NAP guidance on the Global Mercury Partnership website, which is shown, the address shown here. That includes the overarching guidance document, which I showed the cover of earlier, but also guidance on sub-elements. For example, on formalization and on gender mainstreaming. There's some specific guidance documents as well. And then there's also a number of resources, excuse me, a number of resources on health and ASGM on the Planet Gold Knowledge Repository, and you can see the address there. For those of you who are not aware of Planet Gold is a GEF, that is Global Environment Facility funded project, which is meant to assist countries, parties to the convention, to reduce and eliminate, where feasible, mercury use in ASGM. And so you can go to planetgold.org and see many resources there, including on health and ASGM. Next slide. So thank you for your attention. Here's my contact information if you'd like more details on anything I've spoken about. And I do also want to acknowledge Malgorzata Stilo and Ken Davis for from UNEP for their contributions to this presentation. Thank you.
Thank you, Susan. Very nice to hear your inputs. And now we have a minute. And now we have a bit of time for Q&A questions and responses that I can see here have been addressed. And I think, let me see, dental amalgam, why is not included? Caroline Vickers has kindly addressed that it's not included in this meeting, but yes, in the convention, and lots of actions needs to be done there. And we can go further in this topic in another time. Another interesting question is that many NEPs for ASGM are developed by ministers of environment and others without the involvement of health ministers. This includes development of public health strategies under NEP. What can be done to promote better collaboration between environment and the health ministers in this regard? ESACO has kindly mentioned that NEP guidance document does recommend that NEP process start with establishing a coordination mechanism strongly involving ministries, entities of public health. And here I think what we are doing exactly now is an attempt to make the multi-sector collaboration work for different sectors. And this webinar has already been implemented at the global level. And these documents prepared by WHO and colleagues from the Swiss Institute have been recently published, which we trust will be very helpful for the ministers of health to be involved. We are familiar with the fact that the ministers of health have been not in the central part of this development, and that's the reason we are trying to promote these documents. I would like to recall that when the Minamata Convention was under development for writing the text, the World Health Assembly in 2014 has issued a resolution that we know as Resolution 67.11 in order to make the health sector in charge of certain roles and responsibilities for the implementation of the Minamata Convention. With that, it means that we have the mandate to do the actions that are necessary. We understand that the counterparts of the Global Environmental Facility are the ministers of environment, and we also understand that the health sector is very busy with many things, especially nowadays with COVID transmission in ASGM communities, and we would like to promote more actions from the health sector, for which we are doing this right now. There are more questions that I would like to share. What happens when a country with a high mercury consumption does not present the national action plan? Are there penalties? And I see ESACO Toda is already typing an answer. Isaac, if you prefer to talk, you are most welcome, or to continue.
Thank you, Anna. I just clicked the wrong thing, button, and I was typing and response, but basically there's no provision on the non-compliance in the Minamata Convention, but it has a provision for compliance, which is the Implementation and Compliance Committee. So any issue may be raised to that committee to assist the parties to comply with the obligations that includes the development of and submission of national action plans. Thank you.
Any other comments from the ground or from speakers?
Anna, if I could just maybe address a question that just came in about the origins of mercury and the amounts. So there are, it's very difficult to trace the origin of mercury. It is a legally traded commodity in many places, although of course the import rules vary country to country. Nonetheless, there are, once it gets to a country, it's very hard to track where it goes. There's a lot of smuggling, all those things happen. So there are a lot of efforts under the Minamata Convention and in other spaces to try to do work to really figure out the supply chain of mercury and how it's getting to the sector, recognizing the importance of trying to control trade. Regarding the amount used, yes, there is an estimate that is under the Global Mercury Assessment, which was published by UNEP in 2018, I believe. Asako, you can correct me if I'm wrong. And again, I'm trying to remember the exact amount, but it's something along the lines of 1,500 tons per year are used globally in the ASGM sector of mercury.
Thanks, Susan. I just wonder if other people want to comment. I don't see more questions in the Q&A and in the chat. I'm going quickly. In that regards, I think, if we short this session a bit, there is no problem because we can also come back with questions and the answers in other sections. I think we can now go to the next presentation, which is the WHO step-by-step guide, insights and the associated documents. First presenter will be from Mirko Winkler, who is an assistant professor at the Swiss Tropical and Public Health Institute, and also about piloting experiences from Astrid Nobloch, sorry for the accent, postdoctoral researcher at the same institution. Mirko, the floor is yours. Thank you very much.
Thank you, Anna, and warm welcome to everyone here on this webinar, to my short presentation in which I will provide some insights into the piloting project which we carried out for developing the WHO guidance on how to develop a public health strategy in the context of the Minamata Convention. Let me start screen sharing. You should now see my screen, and let us start with giving you an insight into the setup of the pilot project, which was jointly funded by Jeff, UNIDO, and WHO, and it lasted 4 years. For implementing the pilot project, there were 3 main project partners in Switzerland. These included the World Health Organization, the Swiss Tropical and Public Health Institute, and the Swiss Center for Development and Cooperation. In addition, and very importantly, we had several project partners in each project country. You can see here the project countries were Mozambique, Nigeria, and Ghana. So the piloting project had a focus on the African continent, but we are convinced that the output of the project can be used in many contexts all over the world. Now, we had project partners, and we worked in the 3 piloting countries where we conducted different assessments. But before we started to actually carry out any assessments in mining, artisanal gold mining areas, we developed a detailed study protocol, and that was a very important element of the pilot study, because this is where we developed the detailed methodology of the step-by-step guide. And then this draft methodology was piloted in various contexts. And of course, we also applied for ethical clearance for conducting our work. And this included the ethics committees in each of the partner countries, but also the ethical review board of the World Health Organization. Once the required permissions were in place, we started with our assessments. This included an institutional capacity assessment, which was carried out at the central level with key informants who represented governmental entities that have an interest, role, or responsibility regarding artisanal and small-scale gold mining. Once those institutional assessments were completed, we continued with rapid health assessments in 2 artisanal gold mining areas in each country. And so what did we do in those rapid health assessments? We conducted our observations, but then also carried out key informant interviews with local health authorities and healthcare providers. And that was, of course, very interesting, because occupational practices for doing artisanal gold mining varies, of course, not only across continents, but also across countries and contexts within those countries. In addition, we also carried out focus group discussions with artisanal and small-scale gold miners, as well as family members of the miners. And in addition, also focus group discussions with the broader community. So we really wanted to understand the impact on public health from deriving from artisanal gold mining on the wider context, and not only the miners themselves. And in a third final study component, we also carried out health facility assessments with the objective to assess the readiness of the local health system to address ASGM-related health challenges identified in the key informant interviews and focus group discussions. So these were some insights into the methodological approach. And as you can imagine, we focused not only on mercury, but the broader public environmental public health context in those settings. And clearly, mercury contamination is a huge health hazard. And in addition to this, of course, there is several other things which you can see here in this word cloud. And this is actually based on the answers we received from you here on this webinar during the registration process, I wanted to say. Now, a last step then of the piloting project process was that we conducted stakeholder workshops in each piloting country with the objective to build on the evidence gathered in the assessments to develop public health strategies in the context of the Minamata Convention on Mercury. And those public health strategies that resulted from this process were then incorporated into the National Action Plan. So, of course, we also summarized then the findings from the piloting project from the rapid health assessment, but also from the institutional assessment for each of the countries. And if you would like to go into the details of those assessments, we will share the links to those documents with you in the chat. But we can also summarize a little bit the findings from both assessments. So first, the overarching findings of the rapid health situation assessment, we found in all countries that the capacity and readiness of the health system to address health problems specific to ASGM are very limited. And in those 3 countries, often we found that the health personnel was not really trained for addressing or treating, taking care of ASGM specific health issues. And that also applied to the services offered, but also diagnostic abilities. All, were usually just the same as in other places in the country, but not ASGM context specific. And in addition, also then treatments options and referral were often a big problem. And when I talk about referral, then I also mean emergency care was often not available in those ASGM areas. On the other hand, despite risk awareness, sorry, there's something wrong with the animation here, but despite the risk awareness of the mining community, there is usually limited willingness to avoid risks. So that also was an overarching finding of our assessment. Now let's briefly look into also the conclusions that we draw from the institutional capacity assessment. The level of ASGM related health issues that are accounted for in legal frameworks in all 3 countries that varied very much. In some countries that was incorporated, and in others the topic of ASGM and health was not incorporated at all. Then structures, systems for continuously generating ASGM data are often lacking in those 3 piloting countries. And finally, institutional capacities for addressing health in ASGM are often insufficiently developed. For example, there is generally a lack of knowledge and expertise for awareness raising and education of preventive measures regarding ASGM specific health risks. 2 last slides. First, now the 3 main documents that resulted from the piloting project. Here on the left side, you can see a summary report on the findings from the country workshop. Then a second main output was a short document that introduces ethical and scientific principles for human biomonitoring in ASGM context. And finally, the step-by-step guide for developing public health strategies in the context of the Minamata Convention. And you will learn more about this document in the next presentation by Astrid Knoblauch. But of course, beyond those outputs from our piloting project, the WHO has published a series of other documents on public health, environmental health in the context of artisanal and small-scale gold mining. You can find the references and also hyperlinks to the broader suite of WHO documents on this topic in the step-by-step guide. With this, I am at the end of my presentation and therefore handing over back to you, Anna, or even directly to you, Astrid.
Yes, thank you very much, Mirko. I think we can continue with Astrid, and it's very interesting to learn this process because I trust we'll be using this similar or adjusted approach in other countries of the region. Astrid, the floor is yours.
Yes, thank you, Anna, for the introduction and Mirko for the handover. So I'm going to be talking in more detail about the step-by-step guide, kind of following up on Mirko's presentation. I'm also going to share my screen now. There you go. Right. Now, as said, I'm going to give you an introduction to the step-by-step guide published by the WHO. Now, the purpose of the step-by-step guide is to provide guidance on the overall approach into generating an evidence base for the ASGM-related health issues. And this basically is done or rooted. Sorry, I have to start my video again. And this basically is rooted in 2 assessments. One is the institutional capacity assessment, and the second one is the rapid health assessment. Then a further purpose of the guide was to provide guidance for then translating this evidence and the knowledge gained into public health strategies. And also within the guide, we wanted to share lessons learned from the 3 pilot projects in Ghana, Mozambique, and Nigeria. Now, just a little bit background on the structure of the guide. For each step, what we do is we present methodological aspects and the activities within the step. Then we also present the tools and associated templates that are relevant for each step. And as mentioned earlier, we present lessons learned. I want to say this in the very beginning. So any documents you see, any links that you see, and everything we mentioned is available online. So this is the landing page for the step-by-step guide on the WHO homepage. As you can see, the main document is obviously the guide, but then you have all the associated documents and tools as annexes. We have about 13 annexes, which is, for example, the study protocol or the interview guides or the informed consent sheet and so on. So very importantly here, all those documents, including the annexes and the tools and everything, are available in all 6 UN languages, so also Spanish and Portuguese, which really should facilitate the uptake and the implementation of this guide. Now let's go through it step by step. These are the 6 steps. Let me already move to the first step, which is to read the WHO guidance document on addressing health when developing the national action plans on our ASGM under the Minamata Convention on Mercury. And this document really has the goal to place health in the broader context of the NAP process. So for example, it provides guidance on where and how the health aspects should be taken into account during the overall NAP development process. So for example, when establishing the national coordination mechanisms, or when developing a national overview of the ASGM sector. Another document I want to mention is the WHO has put together kind of an annotated bibliography on any kind of literature that is around the Minamata Convention and health. Here also we will share the link for this document in the chat, and you will also be able to have it in this presentation. So this is the first step, to kind of familiarize oneself with the overall topic. Then moving on to the second step, which is the stakeholder engagement. And here, it's really, the stakeholder engagement is seen as something that is starting at the very beginning, but then it kind of runs through the whole process. Although it's titled a step, but it's really an ongoing activity also during the other steps, obviously. So as a first thing, the stakeholders have to be identified and then engaged from the very beginning. And then they should also, we should define the roles and responsibilities of each stakeholder. So this could be, for example, one stakeholder or stakeholder group is focusing on the coordination and the implementation of the assessments, or another stakeholder is focusing on the community liaison and awareness activities. So this could be, for example, an NGO or a civil society organization that is very deeply rooted already in these communities. So these roles and responsibilities are set out. Now, the lessons learned in this step is that we saw that a broad range of stakeholders is really essential in order to develop a relevant and meaningful and also realistic public health strategy. Because we as public health experts, we might, understand better what's going on, anything in terms of health, but then the perspective from the other stakeholders are very much needed to understand the whole realities and characteristics of these communities. The other thing, we thought it was helpful to have working groups within the stakeholders, which really help to coordinate the different activities and really focus on the defined responsibilities. The third step is to plan the assessments. And as I said before, we have two assessments. And here I'm just going to give you a very brief overview on the objectives and the methods of these assessments, but you can read more on this in the actual guide. For the institutional capacity assessment, the objective was to assess the institutional capacities at national and subnational levels to address the ASGM-related health issues. And the methods here used are twofold. It's mainly a document review. So this could be, laws and regulations, or also emergency protocols on chemical spills and so on. It's really anything you can find on the internet, but then also what you've been given by, for example, the key informants, which is the second activity here. So doing and conducting key informant interviews. For the rapid health assessment, the objective was to assess the health situation of ASGM communities and then the capacity of the health system to react to those health needs of the communities. And the methods here is also a revision of the documents, but then the main part is really to go and visit the ASGM communities and sites. And there you do observations, you also do focus group discussions, you do key informant interviews, so you're really involved with the community. Key informant interviews could be, for example, with traditional leaders or with leaders from mining associations, or with civil society organization representatives, and so on. And last but not least, also you go and visit the local health facilities that are serving those people, also the ASGM communities, including the miners, and there understand a bit the health situation, the health statistics, potentially, and also make a key informant with the healthcare provider. So the approach for both this assessment is basically the same. As a first step, you really have to identify and formulate the research question. As a second step, so the research question is basically you will have to know what do you want to know at the end of the assessment. And then you also have to familiarize yourself with the methods which are described in the guide itself, but as well in the annexes of the guide. Then a document review, as mentioned before, to kind of understand what's already going on in the country, what do we know, where are the data gaps, and where should we probably focus our attention on when we do the field work. And based on that, we actually do adapt the tools and methods and templates to the local context. And then last but not least, we have to identify the key informants and select the study sites. Now, the lessons learned in this step is that there are sometimes this make a stakeholder mapping and also obtain these ministry organigrams or organizational charts or something. They really help to understand what is the organization of these stakeholders, and then also this will help you to identify the key informants. The other lesson here, which is very important, so because of the sensitivities often associated with ASGM, the context, the ethical approval process can be very lengthy and very robust. So it is recommended that a robust study protocol is developed at the very beginning and submitted actually to the ethical committee a bit early on in the process, because it could be lengthy. But here the good news is again that the tools and template, they include a study protocol also in the language that you will have to use it for. I'm going to just cross-reference again the document that Mirko talked about before as well, which was another output of this exercise, which is the document on human biomonitoring in artisanal and small-scale mining. So here, this provides also an overview of the internationally agreed ethical and scientific principles that must be adhered to also during these assessments. Moving on to step 4. Again, we have the 2 assessments, and basically this step is about conducting the assessments. And this is mainly collecting the data, but then also after data collection to analyze the data and to write a report with the conclusions. Here, the lessons learned. Yes, when you're in the field, it's important that you remain flexible in recruiting certain key informants, because there might be new key informants popping up in the field that you didn't know of, and someone is recommending someone, and then you should be flexible enough, as normal in field work, that you can recruit other people. Second lesson learned here I want to present is actually, again, something I said earlier, but I just want to emphasize the importance of this, is to include a diverse set of stakeholders. And this is really essential to understand the realities of working and living in ASGM communities. Now, step 4 is about synthesizing the results and making recommendations. For the institutional capacity assessment, this means that, yes, we have to evaluate what are the institutional capacities at the national and subnational levels based on what we have found in the field and in the documents, and then to formulate recommendations at certain levels. So we formulated the recommendations at the policy and regulative level, at the structural level, and at the process level for this assessment. Similar for the rapid health assessment, where we evaluate the health issues, what is going on, what are the health issues in ASGM context, and how what is the health system's preparedness to react to those health issues. And based on that, we formulate, again, recommendations, which we structured at the individual level, the community level, and the institutional level. Of note, these recommendations you can see in the country reports that we put the links in during Mirko's presentation. Now, lessons learned in these 5 steps were that, yes, in this step, it's very important that the recommendations are very comprehensive. Later on, while developing the public health strategy, you might have to prioritize, and you cannot consider all the recommendations or all that or the whole wish list. But here in this step, you should really put a comprehensive list of recommendations. Yes, you see the structure that we have used. You will also see them in the pilot country reports, but basically this could be structured differently based also on country needs and wishes. Another tip here is that we found graphs very useful to present the results, because you're presenting them to various stakeholders who don't have always the same backgrounds, and the visualization really helps to understand for different audiences. Now I'm already coming to the last step, which is the national multi-stakeholder workshop to actually then develop the public health strategy. Now, the objectives of the workshop are to share the findings and recommendations of the 2 evaluations with the stakeholders. So as said, you have a report, but then in the workshop you present it in an accessible way. Then the second objective is to jointly develop the public health strategy based on the findings and the recommendations that came out of those assessments. Now, based on the synthesis and recommendations done in the previous step, the participants then agree on 3 to 5 priority areas in the public health strategy. And here you see the examples from the pilot country, and you also see that Nigeria and Ghana and Mozambique, they didn't all identify the same priority areas. And this really, like the workshop participants decide on it. So it's always depending on the country context and what comes out of the workshop. Then the minimum goal of this workshop is actually to have a draft public health strategy. This can then be finalized or refined later on after the workshop, but a minimum goal is really to have a draft of the strategy already. And here in the picture, you can see the public health strategy developed in Nigeria, which was then, after the workshop, a couple of weeks later, endorsed by the Federal Ministry of Health in Nigeria, and then submitted to the NAP committee. The lessons learned here. Yes, the stakeholders really highlighted that they had direct benefits of these presentations given, where we presented the findings and the recommendations. This really directly helped them to develop the public health strategy. Then they really liked the participative approach. So basically any stakeholders, even those outside of the health sectors, had the opportunity to raise their voice and give their input, even though it was a public health strategy. And then, yes, we believe that the ministries of health should obtain the approval from these various stakeholders present in the workshop prior to submitting the draft to the NAP committee. Now, as a last slide, I want to give you some what we call overall experience or general experience that we have with this approach of the approach presented in the step-by-step guide. So we think that a realistic time frame for the implementation is 6 to 12 months. Depends a bit on the countries. For example, how long does it take to get ethical approval, and then other external factors. For the data collection itself, the institutional capacity assessment, we think 4 to 5 days is was appropriate. And same actually, if you go to the study sites, in order to collect all the data, around 5 days are required per site. So all in all, this led us to 2 to 3 weeks of data collection. Importantly, we think that it's really necessary to have 2 full days for the workshop. That's just the time it requires to present all the findings and recommendation, and then especially the group work and the formulation of the public health strategy, and then come together again and kind of advance it. So at least full day are really recommended for that. And then as a final remark, we really believe that the 2 assessments achieved their objective in generating the evidence base for in the artisanal gold, small-scale gold mining sector, and the health system preparedness. So it created the evidence base to then develop the public health strategy. While I cannot name everyone, I want to thank everyone that was just in general involved in this process of the step-by-step guide, either in implementing it, in conducting the assessments, or in the guide itself. Thanks to everyone, also a lot of my colleagues. Then, of course, the ministries of health in these pilot countries, as well as the WHO country offices and the headquarters in Geneva. And most importantly, I also want to thank to all the people that have given us their time and information during this assessment. So during key informants and focus group discussion participants. And last but not least, obviously, thank you for your attention.
Thank you, Astrid. Very nice sharing your presentation. And in the interest of time, I think we should be very brief with the questions and answers that I see in the cite here that many have already been answered and the others not, that are not directly related to this panel. So I would suggest to leave these questions for the end of the webinar if we have time, or to address them by email in other channels. I'm glad to continue with that. For the next panel on regional country experiences, we'll be talking about the major routes of mercury exposures in the context of ASGM, burning the amalgam and fish consumption, especially in the context of the Amazonian ecosystems. For that purpose, I would like to call Sandra Heikon, who is a professor at the Fiocruz Foundation, Ministry of Health, with extensive experience on mercury exposure among ASGM communities in Brazil, and she can talk with us. I would like to ask panelists, we are very good on time, if you can stick to the 8 minutes presentation would be good. Thank you very much. Sandra, the floor is yours.
Gracias, Ana. Sorry. Thank you very much, Ana. And thank you for the invitation. I think this meeting is a great opportunity for us to share this experience. In the case of Brazil, the source of mercury is not only the artisanal gold mining, but deforestation, road construction, agriculture, stock, hydroelectric reservoir. Also, they contributed with a lot of mercury. It's not easy to have these values, but the gold production is ranged in Brazil from 11 to 106 tons. So the mercury emissions, the mercury emissions also vary from 20 to 200 tons per year. So we have to, sorry, because the sound, I'm talking English and I'm going to, pero o espanhol está, como posso?
The English was coming out. How can I turn off the interpretation? Is that possible?
Okay. Yeah, yes, I did. Sorry, thanks. Okay. So only in Tapajós, we have the range from 30 to 160 tons per year. It's a lot. Okay. And but also, when you talk about exposure assessment of mercury, these vary a lot from the sites in Amazonia, in Brazilian Amazon. However, you have to consider that 90% of methyl mercury in fish comes from the gold mining and the other source, of course. The risk analysis is an important tool to achieve consumers' protection and ensure the benefits of fish consumption, especially for those who depend on fish and their only source of protein. Fish consumption by indigenous and riverine communities can exceed 300 grams per day, which means 100 kilos per capita a year. So this means a real risk for human health. However, these consumptions depends on the gender, age, location of the indigenous land, because if they are close to the river, it's easier for them to get these sorts of food. If they are far away, of course, the levels of mercury is reducing a lot because they use other source of diet. Here is a synthesis of a study in the north of Brazil in the border of Suriname and Guyana. So what you can see here that the carnivorous fish, they present high concentrations of mercury that can range from 1 ppm to 6, 7, sometimes 8 ppm. Sorry, can you go a little bit ahead, please? Can you show? Yes, please, a little bit ahead. Okay, so, so when you talk to indigenous, we have to pay attention what sort of fish we are proposing, what discussion with them in relation to the mercury. Because if you are in the urban area, you have a lot of options and preference, different preference, no? So in that case, mainly from the urban areas, people prefer a big fish, like those that I am showing this slide, which they can get at 20 kilograms. But the preference that you show here, it's is for carnivorous fish, which has the high mercury concentration. You can see in this box plot the difference among carnivorous fish and some other trophic level. So when we propose some changes in the diet, you have to be very, very careful, because you cannot say, okay, don't consume carnivorous fish, because depends on the seasonality of the region. They don't have all these options to get, for instance, herbivorous fish or some other trophic level. So we have to hear them first. You have to know how they manage this situation. Here, we can see very clearly that the frequency of fish ingestion is well correlated with mercury in blood. So if you eat one time per week, even carnivorous fish, you be below the limit, the guideline, the WHO guideline. If you eat more than that, of course, it depends on the trophic level that you ingest. But in general, if you have a sort of mix, eating different sort of fish, you can see that the levels of mercury in blood is started to increase. Indigenous people who live near the rivers and consume fish have a good perception of the meaning of mercury contamination for their health. They know, when you talk to them, you can feel that. However, they usually live near in remote areas, far from urban center, and have many difficulties in obtaining other sorts of food. And even knowing that fish pose health risk, they consume it, not always fishing fish with lower levels of mercury. However, if you guide with them with information and communication. I think we can, I wouldn't say solve it, but you can minimize, you can mitigate the source of exposure to mercury. Here, in the last one, we have the communication, the risk analysis. Here we compare different areas where we have done risk analysis. And you can see that the dose is completely different for adults and the children, which is expected. But how to communicate this information? So we communicate this information using colors, that is easy. Explain to them what are the fish that most have some impact in their health. And they try to follow our information, but not always is possible. So you have to prepare a sort of guide for them, but not for them, with them, because they have a lot of information to pass to us, and they have a lot of histories about how they can consume less carnivorous fish and how they can replace their diet habits, which is not easy to change. So the initiative to help them in their diet has to come from them with us, with our knowledge about the risk of mercury and their knowledge to manage this information. Thank you very much. Sorry about this confusion with listening Spanish and try to talk in English. Sorry about that.
Sandra, thank you very much. Very interesting, your presentation. We understand fish consumption is a big problem in the Amazon. And I think we are going to learn a bit more from Claudia Veiga, who is a senior researcher from the Amazon Science Innovation Center in Madre de Dios, Peru, who has been working on research and interventions in Madre de Dios. Claudia, the floor is yours. Thank you.
Gracias, Ana. Gracias a todos.
Thank you, Ana, and I thank everyone for your attention and for the invitation to this webinar. And I think that this is a very important forum to allow us to share information. I am now going to share my screen. Please let me know if you can see my presentation. Yes, we can. Yes, now we're seeing it in slide format. Thank you. Perfect, and thank you. As she said, I am Claudia Veiga, and I'm the coordinator of the Mercury program at the Amazon Scientific Information Center and work with Madre de Dios. And we've had an intervention with artisanal communities in the region. And for this, I want to tell you a little bit about where this community is located. It's part of the Peruvian Amazon, and it's a hotspot of the university. The Peruvian government designated it part of our biodiversity, and our artisanal mining is an important economic activity. Unfortunately, the sound is making it a little bit difficult for simultaneous interpretation, but here we're talking about deforestation. That's what the deforestation has been, 115,000 hectares or 180,000 football or soccer fields. And there's been some degradation and deforestation. Now, as we all know, artisanal mining uses mercury, and that's the main source. It's releasing approximately 180 tons of mercury per year thanks to this activity. And this brings us to the topic at hand. The average concentration of mercury in the hair of the population of Madre de Dios. So we were looking at different populations in the area and found that mercury levels in the indigenous people was a little bit more than twice as high as that amongst non-indigenous populations. It also showed that 7 out of the 10 communities that had the highest levels of mercury were indigenous communities. This study was conducted. Here you can see you can see the different colored areas. Green is, well, you can see in the yellow, the artisanal mining. The pink is mining and deforestation. This is around Madre de Dios. And you also can see a concern about levels of mercury in communities that are even further away from artisanal mining. And here we have a national park, a communal reserve, and this just had recent contract in 2014. There was a project done with this community, and it was observed that in this Maisal community, which is upriver from the mining activity, as you can see in this graph, had rather elevated levels of mercury compared to 2013. It was more or less 30 ppm. And as you can see, there was a major difference in the mercury levels of the non-indigenous community. So I'm talking about the community of Maisal on the right. As Sandra said, and as you could see on the map, the community is very isolated, remote from rural areas, rather urban areas. Their diet is basically based on fish consumption. Most of the community eats fish every day. And this somewhat explains the level of mercury that we found. And at the end of 2017, beginning of 2018, there was also concern about these communities. Maisal was not the only community impacted along the Rio Mano, the main river, and there are others. We were looking at Yomibato, Cayucatal, and Tagyome. In 2018, there was concern about mercury exposure, and they began to evaluate these communities as well. So in 2018, we studied Maisal and these other 3 communities. And so we went into the communities and presented the community plan. We had a general assembly in these communities. And as I said before, the community participated or approved the study and take advantage of the fact that we were there to assess mercury. We obviously looked at the health status of the community. We did a rapid health assessment and took mercury samples from the community, and we also took samples from fish.
And what we observed was that indeed mercury levels, there were a number of expeditions that were undertaken during these various years, 2017, 2018, and we observed higher levels of mercury. And as Sandra mentioned, at that time, we need to consider the time frame in the Amazon area at that time. And during the drought season, that's when we see the greatest impact and the highest levels for the communities. The study did verify these higher levels, but Additionally, in 2018, the Cautale and Yomibato communities also recorded higher levels of mercury, and these were above the levels established by WHO. In terms of the rapid health evaluation, we observed that there was a chronic and acute malnutrition demonstrated by children on the order of 40% in the communities that were subject of the study. We continue to work on these factors that affect the various communities. And right now, we're trying to work on different communities and adapting our methods to try to detect the more significant impacts in each community. We do have some preliminary information, and one of the conclusions is that we don't know what the sources of mercury are for fish, especially in communities that are distant from artisanal or small scale mining operations. As Sandra mentioned, there can be a number of factors that can influence the presence of mercury and that can exacerbate the concentration of mercury in our metabolism. And by understanding that indigenous communities rely entirely on the natural resources that are available to them, then we're trying to ascertain what the source of the mercury is. Diet is a key factor in mercury exposure for indigenous communities, and we've seen this in different regions in the Amazon area. And again, we verify that indigenous communities are much more gravely affected to the exposure than other non-indigenous communities. And as Sandra already stated, how do we address this issue? It's not just a matter of changing your diet. As you can see on the map, the distance between these communities and these mining activities are above 100 kilometers. It took 2 days on a boat to reach those communities. So the access to these areas is rather complex and it makes it more difficult to address the issues. And this was one of the concerns that we had because, as it was already mentioned by Mirko, we have to look at the health situation in a more generalized way and then focus on the mercury exposure issue. But we need to come up with the most effective solutions and plans for each community. So what is it that we did with this information that we garnered with the study? Well, as Sandra stated, we first have to share the information with the community. We produced a video that included the information in a way that was easy to understand for community members. And despite the fact that they are located in a very distant place, in some parts of that world, there are cell phone service there is cell phone service availability. And I'm not going to show you the videos today because we don't have the time, but they basically summarize all of the information that we've collected. It focuses on mercury information. There's a didactical approach that we used, and we experimented with different target groups to see how the information was absorbed by the community. As Sandra stated previously, community members understand the problem and the issues, but we still wanted to share more information. Another thing that was very important to mention is that these are communities that are highly dependent on the surrounding environment that they live in. And for that reason, they have extensive knowledge about those natural resources. So their input was extremely valuable for our purposes. And so we involved many women in our process. We conducted workshops, and in these workshops, we heard from local women. And this was something that was done in Puerto Maldonado, but this information was also disseminated to other nearby communities. We also shared information about the type of foods that could be leveraged or could be used as a supplement or to supplement their diet regimen. Now, this was something that they developed on their own, and so they can see a breakdown of the available products available for each month of their year. And in this way, they could come up with a more balanced diet using alternative natural products. As Sandra already mentioned, the idea was to look for a solution in conjunction with the community's intervention, and they were part of this information collection process. We also provided information to them about the studies that were conducted, and this information was presented during an environmental conference. And at present, we are training a health promoter that provides services in these communities. And the idea is to improve their diet, but we can't ask them to do something if they don't have the necessary availability to these food products. I'd like to show you a photograph that we just got 3 days ago of the health promoter, and she is sharing and presenting the information that was generated. And you can see where the child is. There's additional information on the table that addresses issues related to mercury exposure. This is what we've been doing at the community level. Additionally, we identify alternative food products that can be produced locally. And this is something that allows them to seek other alternatives to their current dietary regimen. So in the end, what we want is for them to have a balanced diet using the resources that they have available to them. And I wanted to use this strategy because for them, it wasn't so much a mercury issue. In these interventions with indigenous communities, we need to adopt a broader approach. So we're working on the dietary regimen side, we're working on the information dissemination side, and this has allowed us to achieve some progress in trying to help these people get to a better framework in terms of their balanced diet. And
Este tipo de trabajo no lo hacemos solos, lo hacemos con
so
varios
we
otros.
don't do this work alone. We do this through a vast partnership, and we have relationships with Wake Forest University and USAID. And I wanted to thank all of the people that work with us to implement this strategy. And it's key that their support is absolutely indispensable for our efforts. Thank you very much.
It's short on time, but very rich your presentation. Thank you very much. I would like to call now Ana Carolina Castillo. Sorry, I forgot to put my from Honduras Environment. That she is going to talk about some experiences about mercury exposures in ASGM communities in Honduras. And I would encourage Ana Carolina to be very quick because we are very short on time and we still would like to hear Julius Decon from Suriname and some final remarks. Thank you very much.
Muchas gracias.
Thank you very much. I will share my presentation now. Can you see it? Yes, we can. Thank you very much for the space that you've provided us in our Secretariat of Natural Resources and the Environment. And thank you for the opportunity to share some of the conclusion of a study that we conducted on ASGM in an area called El Corpus. The content of this presentation focuses on two basic locations. We're going to talk about the objectives, the methodology, the results, and the considerations and perspectives derived thereof. In terms of the context, Honduras ratified the Minamata Convention in 2017, and they finalized their National Action Plan towards ASGM this year. We understand that this kind of practice is the most important contributor to mercury exposure and the second source of the national inventory, the second most important source of the national inventory of identification and quantification of emissions and uh, of mercury in Honduras. We have approximately 48 municipalities, 61 communities with active ASGM operations covering more than 2,500 miners. So the UNDP, in conjunction with other organizations, undertook efforts to ascertain what the situation with regard to ASGM was in El Corpus, and they conducted a baseline socioeconomic study in 2017. So this is a map of Honduras and the municipality of El Corpus, which is in the southern portion of the country. This study was developed in 2015 to 2019, and we had the intervention by three key actors, and these are the environmental sector, health sector, and the mining sector. Our zone that was subjected to study included the state of Choluteca, the municipality of El Corpus. In this municipality, we have five different communities that depend very heavily on ASGM activities and a total population of approximately 30,000 inhabitants. This has been an important contributor to the problem at the national level. About 5% of the miners are represented by women and by child labor. The production of ASGM in El Corpus was approximately 132 kilograms in 2016, which is equivalent to 659 kilograms. This is a timeline that describes the situation related to mercury exposure. And what we've seen is that in the extraction phase and the subsequent separation, titration, and transportation, we see that the exposure is relatively minor. But when we move on to the processing or grounding, the level of risk is moderate, but the greatest risk appears with the amalgamation process and the burning procedures that they use for that process. This was a brief, or this is a brief description of the study. We had not undertaken these types of studies previously in terms of the degree of exposure and human intoxication due to mercury derived from ASGM operations. What we tried to do with this study is to ascertain the magnitude of the problem. So the assessment of this exposure employed a quantitative instrument that was designed for this particular study, and it allowed us to determine the degree of intoxication based on the evaluation or assessment of clinical manifestations and mercury biomonitoring. The objective for the project was to determine the magnitude of the exposure and the risk of intoxication due to mercury in the ASGM population located in El Corpus. The specific objectives included determining the level of mercury exposure within the population and determine the levels of intoxications due to mercury as a result of exposure in the mining population. This was the timeline that we established from the beginning of this study. Honduras, we've had the capacity to analyze mercury using other techniques that are not, how shall I say this, the best. We do have better techniques to assess mercury exposure. And so we had to buy some very specific medical equipment to be able to make these mercury determinations. And with regard to the environmental sampling effort, we had to use other equipment. This is not the type of equipment that is used in the health arena. So we had to avail ourselves of support from the national government to be able to assess the presence of mercury. This included the uh, inputs, evaluations, and other procedures for us to get the proper results for the study. We also set up a multidisciplinary team to develop this research project, and we also worked with the technical consultant to provide support, technical support for this study. So we established local groups as part of this study, and not only in El Corpus, but in the surrounding communities around El Corpus, and we included health personnel, and we also provided some training to be able to conduct the study. And in June, we were able to develop the documentation for the study. We also empowered the local groups to support the project there in El Corpus. Additionally, we conducted awareness campaigns with the surrounding communities in addition to El Corpus, primarily geared towards health issues. This is a project that was approved by the Ethics Committee for the biomedical school at the university, at the local university, and they supported the implementation phase. Once we began the implementation phase, we started to track the various sources for the uh, mercury itself. We developed all of the equipment, identified the different team members that would be working in place. Once we identified all of the participants in the study, we started to validate the information, analyze the chemical, health, and environmental aspects related to the study. We conducted extensive biological sampling on local residents, and we also conducted the necessary laboratory analysis for the results. Once we obtained the data and the results, we conducted some statistical analysis related to all of the collected information and came up with a technical report for the results. We also established a communication plan for the risks at the local level and at the surrounding community level. We also extended this to the state level as well as to the CNG and other areas. And by creating greater awareness about the results of the study, we were able to address different authorities at the central, state, and local levels. And additionally, we created awareness among local community residents. I just wanted to briefly show you the results. These are the occupational exposure levels. We also looked at the mercury assessment or assessment levels, and we also assessed the degree of mercury that was contained in the different food sources. And this was done both in mining areas as well as non-mining areas. And in both, we saw an elevated level of mercury. So we also established a subset of references for or reference values for mercury using these biological indicators. We set up a rating scale. Low refers to the first limit of exposure, and we also have subsequent levels between the first and second level, and much of this analysis was conducted on urine samples as well as hair samples. We subsequently conducted evaluation process for intoxication due to mercury based on these results. And we concluded that the most severe impact for minors is in this middle portion here, whereby we see 58% of exposure. And among non-minors, this level was on the order of just below 42%, which was deemed to be a low range. These were studies conducted on urine samples adjusted with creatine. Now, when we did the sampling on hair, or when we used hair samples, we saw that the low or safe levels of exposure in minors, it was 59.3%, but in non-minors, it was at 85.4%. So the evaluation of mercury, total mercury determined by laboratory testing on both urine and hair samples. We conducted a general comparison of mercury levels in urine and hair samples based on the baseline exposure values. So in hair samples, we had a certain average, but something that caused a red flag for us was the levels of mercury that we detected in urine samples. In terms of the conclusions, there does exist a generalized exposure to mercury in the ASGM community and El Corpus that is influenced by the intensity and variability of the operation itself. The chronic exposure to mercury for the ASGM community is on the order of 95.4%, and there's and the non-mining population had an exposure level just below 50%, but the presence of this type of exposure is in non-mining areas. We also saw that the environmental factor reveals the presence of mercury in non-mining populations. So the exposure to mercury in the diet is a relevant factor for all of these populations. And intoxication due to mercury was predominantly represented by males, and this coincided with the ASGM value or supply chain in El Corpus. This work demonstrates a very high utility for diagnostic purposes and epidemiological monitoring to track mercury intoxication in ASGM communities. So many of the results derived from the study were extremely positive because it allowed us to not only identify future research to be done, but it did shed a great deal of light on the problem itself. This is a picture of many of the local participants that aided the development of the study.
Very interesting to learn about this experience in Honduras. And I would like now first to ask your permission of all participants to stay 5 minutes longer so we can have Jules Decon from Suriname and also some final remarks of Caroline Vickers while you just put in my PDF one slide presentation at the end. So Jules Decon is from the Ministry of Health, Suriname, and is going to share some insights about the public health in the context of ASGM in the country. Jules, the floor is yours.
Yes, thank you, Anna. Thank you for this opportunity to share some thoughts on the ASGM issue and public health issues in Suriname. What I will do, I will give a brief introduction and on the ASGM, some data on the population estimates, the healthcare issues they are confronted with, and the NAP we are developing at this moment, we are finalizing this moment, and some public health issues and the follow-up. Can I have the presentation, please? Yes, okay, that's the first slide. Well, we can move on some time to the next one. Well, in this slide, I'm giving you a brief overview of some characteristics of Suriname and the ASGM. Well, the total population is 600,000 inhabitants, relatively small. We have a forest coverage of 93%, and it's mainly tropical rainforest. And we have some data about the gold production in 2019. Large-scale gold mining is happening in Suriname. There are 2 multinational mining companies. And there's ASGM mining, and the total produced gold is 36.5 metric tons in 2019. And the gold is 78.4% of the total export. And the main export countries are, in order of appearances, Switzerland, UAE, Belgium, and the USA. On the right side, I have a map of Suriname. The capital city of Suriname is Paramaribo. And the shaded area, that's the area, the so-called greenstone belt regional area, where all the gold mining is mainly taking place, the ASGM and the large-scale formal gold mining. The next slide, please. Next, please. Yes, in this slide, the shaded area, I've populated it with, please backwards. Can you go one up, please? Well, yes, no, I think you're going too fast. Yes, yes, this one is okay. Well, in this slide to the left, in the shaded area, I've populated it with the villages that are located in this area. There are Maroon tribal villages and there are indigenous villages in this area. And on the right side there is a map with the concession holders of extraction, of exploitation and exploration rights. And the green side to the right, to the left, sorry, is the Central Suriname Nature Reserve that's very close by to some of the mining activities. Next slide, please. Well, on this slide, I have some information about the population and demographic estimates. In the ASEM sector, the total people who are involved are 20,000. And the people who are actually involved in the mining process are 10,000. 20% are women in the ASEM population. Also, children are involved. 400 are living in these areas, and 125 are actually involved in the ASEM activities. The average age of the people is, for men and women, is around the 40s. And the ASGM, it may provide 9 to 30% of the income of the total population. Next, please. Next slide, please. Yes. Well, in the ASGM population, 1/3 are Surinamese nationals and 2/3 are foreign migrants, primarily the Brazilians, the so-called garimpeiros. And also there are a small but growing number of other migrant workers involved. And mainly women from the Dominican Republic, Cuba, Guyana, and Venezuela, and also from China, predominantly men. And the ASGM population is characterized by low levels of formal education. Next. Well, when we look at the access to healthcare and information for the ASGM population, it's limited. And some reasons that can be listed for that is that it's often takes place AGM in isolated areas in the hinterland, and there are no health posts or clinics located over there, or when they are located, it's some distance to travel to those posts, and it is costly in terms of financials and also in time. And there are language barriers for migrants. We speak Dutch in Suriname, but also our local language, Tongo, but still there is a barrier for some of the migrants. The lack of health insurance and the level of trust there is in home remedies or informal networks. Yes. Well, at this moment, I already mentioned it.
that they are shared by many countries. Sorry for the noise here behind. And I would like to ask colleagues from Swiss Institute to put my slide only for information, and Caroline Vickers to say some words for us. I assume that most of the questions in the chat had been answered, and if not, we can continue with more interactions in the future. Caroline, the floor is yours.
Thank you very much, Anna, and also to the presenters and to everyone who's joined us today. I wanted to leave you with just a few remarks. Firstly, we have heard today reinforced how important the issue is of addressing mercury exposure in ASGM. This is a significant health issue for more than 80 countries and tens of millions of people. The health impacts are severe and they can be very long-lasting in the direct communities that are exposed, but also because of the broader pollution, other communities can also become exposed to mercury. The role of the health sector is really crucial. This is what we do. This is our job. We need to address health issues in a holistic way, not just addressing mercury, but the other health effects that we've heard about today that are faced by mining communities. We need to work with other sectors in doing this. So how can we do this? Through the development of the public health strategies and their implementation, we can set the stage for working within our own sector and also with other sectors, set out the activities that we need to undertake, get the resources to do it and implement them. So WHO has developed the guidance to help you do this, the guidance that was presented today and will be looked at by the COP when it meets, COP4. It will be important that you please use the guidance and that you let us know if you need help from PAHO or from WHO in implementing the guidance. Let us know how we can support you. Also, we heard today from the Minamata Convention Secretariat about the important COP meeting that is coming up. Please get in touch with your representative to the COP. Tell them how important this issue is to you and to the health of the people in the country, and what you need in order to address it. What resources do you need? What sort of networking do you need? What tools and information you need? Because the Minamata COP is a good place for the countries to share their experience on this issue, as well as workshops and webinars like this one that PAHO has very kindly organized today in collaboration with the Swiss Institute. So with that, I leave you good afternoon, good evening, and I hope you found this webinar useful. Thank you. Bye.
Thank you very much, Caroline. Just a bit more of announcements. We have provided, we have drafted some questions for you about this webinar and the follow-ups. So after this webinar, we'll be doing, you'll be receiving bilingual questions that are very brief, and your contributions and the thoughts will be most welcome. So I want to thank you very much for your participation and interest. We hope to continue working with you. And we do have a self-learning format Mercury course. We understand that capacity building is important. And in the PAHO virtual campus on public health, we have this in 2 languages, self-learning course of mercury effects in human health and environments and considerations under the Minamata Convention. You are most welcome to participate, to attend, to see what's there, to make comments and critiques as appropriate. And thank you very much for your attention and interest in our work. We can finish right now unless someone wants to say something from the panelists. We can close the meeting. Thank you, everybody, for your kind participation. Here we are.
Bye-bye.
Thank you.
Thanks.
Gracias.
Thank you, everybody.
Muy bueno meeting.
Thank you.
Thank you all.
Gracias, gracias.